Hello, and welcome to everyone joining us for this Astro Ask a Radiation Oncologist session focused on the multidisciplinary approach to lung cancer care. We're pleased to do this session in partnership with CancerGRACE. My name is Dr. Edina Wang from Duke University Medical Center in Durham, North Carolina, and I'll be moderating this session. Through this session, we hope to answer questions you may have about how the cancer treatment team works together when setting up a treatment plan for people with lung cancer. Today, we have a panel of medical professionals representing different medical specialties who will share the many things they do to make sure that a patient's treatment process is safe and effective and represents the best options for the type of cancer being treated. Joining us today to help answer some common questions are Dr. Jed Gorden, the Director of Interventional Pulmonology at the Swedish Cancer Center in Washington State, Dr. Isabel Preeshagul, a medical oncologist at Memorial Sloan Kettering in New York, Dr. Henry Park, a radiation oncologist at the Yale School of Medicine in Connecticut. Welcome to all of you, and let's begin with the first question. Dr. Gorden, let's start with you. Can you please tell us about the different types of lung cancers?
Yeah, thanks a lot for including me in this discussion, and thanks for everybody tuning in. Lung cancer is something that we talk a lot about, but I think we need to clarify it into its different categories so that we don't alarm people, but we also are able to sort of figure out ways to approach it. And the first thing I think that's really important in talking about, what are different types of lung cancer is to say that things that have traveled to the lung may exist in the lung, but they're not lung cancer. I oftentimes hear from people who have other cancers that are now in the lung that they have lung cancer. And I think it's important first to define that lung cancer is when the cells or the tissue of origin comes from the lung, not a tissue of origin like breast or another that has traveled to the lung. This is a very different type of process and would be treated completely differently. When we're talking about lung cancer specifically, we typically break it down into two large buckets: non-small cell lung cancer and small cell lung cancer. And, unfortunately in medicine, we're not that creative, right? Either they have big cells and it's non-small cell, or they have smaller blue cells and they're small cell. But these are the two large buckets that I think that we need to talk about, and that on the interventional pulmonary side, or when we gather tissue and start making the diagnosis, we need to start with these branching points till we get down to a true defined point that then medical oncology and radiation oncology can start coming to a treatment plan. And before you get to that treatment plan, we need to define it. So you either have a small cell cancer or a non-small cell lung cancer. And then within the non-small cell lung cancers, we really need to get a lot more specific because there's different cell types. And you'll hear words like adenocarcinoma and squamous cell carcinoma. But really, what becomes important now in 2022 and as we go forward is not just these names, but the specific genetics of each one of these tumors. Because our ability to treat them and come up with plans becomes much more specialized and much more personalized to the individual the more we understand about them.
Thank you. Our next question is, what are some risk factors for lung cancer?
Yeah, this is a great question. So the traditional and what remains one of the largest risk factors for developing lung cancer is unfortunately tobacco and tobacco use, tobacco exposure. Cigarette use throughout time has been associated with a multitude of cancers and other medical problems, and still remains the leading cause associated with lung cancer itself. There are other causes that can occur, and one of the things that people are going to hear more about as time goes on is friends or family or someone who never smoked and had lung cancer. So while smoking remains the largest cause of lung cancer, there are still those that have either other exposures, whether they be radon or some sort of work type exposure, or those that just have a genetic predisposition. So there are trends where more people are being identified who never smoked, but smoking still remains the number one cause. And while it doesn't directly address this question, I think it's important to maybe bring it up at this point, which is the notion that because we've been able to identify that smoking is the number one cause of lung cancer, we actually now have screening for it. So, CMS or Medicare qualifies people for lung cancer screening if they're between the ages of 50 and 77. And if these individuals now have a 20-pack year history of smoking, so you either smoked 1 pack a day for 20 years or 2 packs a day for 10 years, and you're actively smoking or quit within the last 15 years. And I think it's really important that while there are those that don't qualify for lung cancer screening, many people do, and not enough people are taking advantage of this. And it's very simple. It's a low dose CT scan. It takes just minutes to go through the CT scan, and it has and will continue to have a dramatic impact on reducing the mortality and morbidity associated with lung cancer. So I think it's important to bring that up around this notion of the risk, which is smoking, but also how to mitigate that risk through screening.
Fantastic. Thank you. What tests may be involved in the diagnosis and management of a lung cancer?
Something typically brings people to medical attention and an image is done. It often starts off with an x-ray, but then goes to a more sensitive x-ray, which is a CAT scan or a scan that really gets very high resolution images of the lung, both normal and abnormal findings. So once we identify that there is something abnormal, you have to go through this process in your head, which is, do we put this person under surveillance? Meaning, do we get another CT, say, in 3 months and see if it's going away? Do we get another CT in 6 months to see if it's growing? Or is our concern heightened that actually, well, I'm concerned based on the patient's risk factors and what the images look like. And those two things together make us worried enough that we're going to go in and get tissue. And oftentimes with lung cancer, the process of figuring out if it's lung cancer starts with a tissue biopsy of some different variety. And there are several ways to get tissue. They involve either going through the airway, which is typically called a bronchoscopy at some point, which is a camera on a stick that goes down into the airway. But now we have very specific tools. You can put an ultrasound machine on the end of that camera, and now it's called an endobronchial ultrasound or an EBUS. And the camera goes down, and then we can look around and look through the airway wall and find lymph nodes and abnormalities and stick needles in and get tissue. There's people who have lesions out in the periphery, and we can use different forms of navigation tools to allow us to go outside of the central airways and beyond where we can see with catheters and identify nodules and get tissue samples. We can ask our interventional radiology colleagues to put individuals who have abnormal images into a CAT scan, and then they can take a needle and go through the chest wall and directly into the lesion and get samples. Or in certain circumstances, we ask our surgical colleagues to go in and get tissue from the lung as well. If it's a cancer, is the origin cell lung? If its origin cell is lung, is it this adenocarcinoma or squamous? And then we get the genetics from it. So what's very important is that when we're thinking about the appropriate test, we're thinking about doing a single test. What we want to avoid is when an individual goes in and does a test where they try to get tissue and it's not high enough yield, and then we have to go in and do a second test. This often exposes people to increased anxiety, increased risk, increased time and delay. So the procedure and the proceduralist and the team that's seeing people should really have a discussion about why they're doing the test and how this test will be the most beneficial test and get the most information possible so that you can move rapidly from the testing phase to the treatment phase. And that testing should include tissue sample, a tissue sample sent to make sure that it's a lung cancer, and a tissue sample, depending on where that is, there's different nuances on whether we figure out the genetics of it. And this gets a little bit complicated, but it's important to have a multidisciplinary team involved to make sure that all the appropriate testing gets done. And the reason that this is important is because on the interventional pulmonary side or upstream when we're getting tissue, we're getting all the information that the medical oncologist and the radiation oncologist and the surgeons who do the treating are going to need to make a decision and a care plan.
I'd say the one thing I'd add to that even further is that is the importance of staging, and knowing what stage of cancer you have from the beginning, because that really does influence the type of treatment that you receive as well. And when it comes down to getting a biopsy, a lot of times you want to biopsy the area that would give you the highest stage. Because if you just get a diagnosis, that's helpful. But then if you then that may require a second test to find out if you actually have had this cancer spread to other organs as well. But that's why this process can take a while, and for some patients, this can take weeks to even months to get a firm diagnosis that leads us to a treatment plan. But at the same time, we also have to take that into account as well. The fact that the pace of the cancer, sometimes they are slow growing and sometimes they're fast growing. Sometimes we have time to do these tests in a safe way and a very comprehensive way, and other times we have to get moving on treatment quickly, even if there's not a complete information at that time that we have from all the tests we need.
I just kind of want to piggyback a little bit off of what Dr. Park and Dr. Gorden just said. And also thank you to Astro and CancerGRACE for having me for this exciting event. I'm learning so much just hearing you both speak. So I think both of you are kind of touching upon tissue stewardship, which is so important. As a medical oncologist, we really tailor to your tumor, and we're going to be talking about this more a little bit later. But really making sure that, you know, when you go in there, you have the right approach that's going to be the least invasive, but also the highest yield. So it's not very, you know, it's very upsetting to the patient when you have to say, you know, we went in there, you went through this big procedure, we didn't get enough tissue, or we got enough tissue for X, but we didn't get enough tissue to test it deeper to see if you have any mutations. So making sure you have the right approach, you choose the right area, you sample enough. Those are all really important things. So I can't emphasize enough the importance of knowing where to biopsy and getting enough tissue.
How common is lung cancer and who is most at risk?
So I'm happy to help with this one. So I'd say every year in the U.S. there are over 200,000 patients who are diagnosed with lung cancer, and it's pretty equally divided between men and women. Right now, it's considered the second most common. I think it's the second most common type of cancer among both men and women in the U.S., and actually the number one cause of cancer death in the U.S. as well among both men and women. And as we heard earlier from Dr. Gorden, who's most at risk are people who've had cigarette smoking histories, but there are other risk factors as well. If you have exposure to radon in your house for a long period of time, if you've had secondhand smoke exposure, if you've had a history of lung cancer yourself, you're more likely to develop lung cancer in the future, as well as a family history of lung cancer for those who are in your family. If you've had prior radiation to your chest to an extensive degree, especially at a younger age, that could raise your risk as well of developing lung cancer in the future. But like Dr. Gorden said, there is a substantial portion of patients who have never smoked cigarettes or really been around cigarette smoke much, who do get diagnosed with lung cancer, and we seem to be seeing that more and more all the time.